All right, it is 12 o'clock, so we're going to go ahead and get started. We've got a little bit of a preamble today before we get to our speaker, but I want to welcome everyone to Medical Grand Rounds here at the University of Colorado. I'm going to leave that up for just a second so you can get credit for Grand Rounds. As a reminder, all Grand Rounds do have CME and MOC credit this year. Just as a brief reminder, next week we are off for the Thanksgiving holiday, so please do not come to Grand Rounds next week. I will never say that again. But we will not be here. We will be restarting the following week with Dr. Mylène Hahn, who is from the University of Michigan, who's going to talk about her incredible work in COPD, which she's calling the Achilles heel of lung health. I'm going to step down for just a second, and I'm going to invite our Vice Chair for Faculty Development, Dr. Sunita Sharma, to come up to the podium and talk about the many faculty promotions that have happened in the last several months. Dr. Sharma.
Thank you, everyone. For those of you who do not know me, my name is Sunita Sharma. I'm the Vice Chair for Faculty Development for the Department of Medicine. It is my distinct pleasure to be able to be here today to really talk about one of the marquee achievements in academic medicine, which is promotion. The Department of Medicine is one of the largest departments in the school, and in July 1st, 2023, we were able to announce the marquee achievements of 68 faculty in the Department of Medicine who were promoted to associate professor, and professor with tenure. And I just wanted to take a minute to highlight all of the achievements of the individuals in our department, because this is a moment that I think really should be celebrated. And so I wanted to just take a minute to really say congratulations to all of the people who were promoted to associate professor. As you will see, there were in total about 42 individuals who were promoted to associate professor in this cycle, so who were promoted as of July 1st, 2023. And so I wanted to take a minute for everyone to recognize this achievement and say congratulations to all of you who have been promoted, both here in the room today, as well as those of you who are online. So please give a round of applause to those who were promoted to associate professor. I also wanted to highlight those who were promoted to professor. As you can see here, these are people across the Department of Medicine, both here at Anschutz Medical Campus, at Denver Health, and the VA. And I just wanted to say congratulations to all of those that were promoted to professor. And then, And then finally, those who are promoted to professor with tenure, again, a truly marquee achievement for these individuals. And so please join with me in a round of applause for all of our Department of Medicine faculty who were promoted in this cycle. For those who were not able to come today, we have certificates that we'll be giving to all of you from the School of Medicine to really highlight this achievement. And I hope everybody's taking the opportunity to celebrate this. So thank you, and thank you for the time, Jeff.
Thanks, Sunita. And congratulations from me as well to each of these members of our faculty. It is an incredibly hard thing to get promoted. So thank you for the personal amount of work that you put into this, but also it's a testament to department and divisional leadership. It takes a lot of mentorship to get people across this finish line as well. So thank you to all of our division and department leaders. Okay, so now I am very pleased to welcome our speaker today, Dr. Joyce Lee. Dr. Lee is an associate professor in the Department of Medicine here at the University of Colorado. She's the director of the University of Colorado Interstitial Lung Diseases Program. She's the program director for the Advanced Pulmonary Fellowship in ILD, and she's the senior medical advisor for the National Pulmonary Fibrosis Foundation. Dr. Lee did her undergrad work at Northwestern University, where she graduated summa cum laude. She was also a medical student, an intern, and a resident at Northwestern as well, before moving on to UCSF for her pulmonary and critical care fellowship. While at UCSF, she did her postdoctoral research fellowship training in the lab of Dr. Michael Mathey. Many of you are probably familiar with the Mathey-Ware model of ARDS. And she was also completed a master's in advanced studies and clinical research in her time at San Francisco. Even if you are not in pulmonary medicine, you may know Dr. Lee's incredible work from her 4 Blue Journal papers published in this past year, and if not that, from her excellent review of cryptogenic organizing pneumonia in the New England Journal, also in this past year. Dr. Lee's research focuses on advancing the clinical and translational understanding of scarring lung diseases in particular IPF and connective tissue disease-associated interstitial lung diseases. Work in her group encompasses risk factor identification and modification, risk prediction, modeling and survival, diagnostic testing, the genetic underpinnings of these diseases, biomarkers, quality of life, both for her patients and for their caregivers. And her team's approach, I thought, was really wonderful to share. It focuses on the four main issues that she sees within her clinic and research investigation, which is the clinical care of these patients, the education of trainees around their care, community outreach for patients and their families, and research into this complex set of diseases. It truly is an honor to welcome Dr. Joyce Lee.
Good afternoon, everyone. Thank you so much to Jeff and the committee here for the invitation to speak at Medical Ground Rounds. Truly honored to be giving this talk here. So we're going to step right in. I'm going to be talking about advances in rheumatoid arthritis-associated interstitial lung disease. Here am I, oh, wrong direction. The right direction, here we go. So here are my disclosures. So the objectives of my talk today are, number one, to recognize that ILD is an important comorbidity in patients with rheumatoid arthritis. Number two, to perform the initial workup of respiratory symptoms in patients with rheumatoid arthritis. And finally, to describe general treatment approaches to patients with RA-associated interstitial lung disease. So in order to achieve those objectives, we're first going to start with a case, and then I'll talk very briefly about broad pulmonary manifestations of underlying autoimmune disease. And then we're really going to do a deep dive into rheumatoid arthritis-associated interstitial lung disease. I'll share with you what we've learned about the epidemiology, risk factors, and prognosis associated with this condition, as well as our approach to diagnosis, a management overview, and I'll end with some high-level conversations about the active areas of investigation that my group and others are doing in this space. So here's our case. So this is a 66-year-old female who reports a chronic cough for the last 6 months. This comes and goes, worse with talking, and occasionally productive of scant clear phlegm. She went to her primary care doctor for initial evaluation, was found to have an abnormal chest exam and subsequent chest x-ray, which led to a CT scan and referral to our ILD clinic. Between her referral to our ILD clinic and her visit with me, she developed pain in her bilateral hands, shoulders, and hips. She thinks she's had some breathlessness that started around the same time as the cough, but now that pain predominates her clinical picture, she's not sure if she has shortness of breath. Her additional review of systems are negative. Her only other past medical history is that of GERD and osteopenia. She's allergic to amoxicillin. Her medications include pain control with Tylenol, diclofenac, and oxycodone as needed, and she takes a PPI for her reflux. She tells me that she has a mother with lung disease, but she's not sure what it's called. Her social history, she's a former 8-pack-year smoker, quit at the age of 24. She denies any vaping or marijuana use. She worked in administration, so primarily in an office-based setting, but recently retired. She denies any exposures to toxic dust, chemicals, or fumes, no exposure to asbestos, and no bird or bird feather exposure or mold exposure that she knows of. On physical examination, she is afebrile, mildly hypertensive, saturating 92% on room air at rest. She has bibasilar crackles by exam, a normal cardiac exam. And on musculoskeletal exam, she has inflammation and tenderness of her MCP and PIP joints bilaterally, as well as her bilateral wrists. She has difficulty lifting her shoulders, bending her wrists, or making a fist due to pain. And with ambulation on 6-minute walk testing, she desaturates from 93% to 89% and walks 915 feet. This is her pulmonary function test. You can see on the right-hand side, her flow volume loop looks reasonably normal. Her FVC is 3 liters or 104% predicted. FEV1, 2.45 liters or 109% predicted with a ratio of 82%. Total lung capacity is normal at 84% predicted. And her diffusing capacity is 13 or 66% predicted. And this was interpreted to mean that she had no restrictive or obstructive ventilatory defect, but she did have an isolated reduction in her diffusing capacity. Her other workup included some blood tests. She was found to be CCP positive at 32, RF positive at 90. She had elevated inflammatory markers of ESR and CRP. She had normal immunoglobulins and normal CBC, LFTs, and chemistries. She got some hand films based on her pain, and they did not identify any erosions. So now we're going to walk through her CT scan images. These are prone images, and you can see here, see if I can coordinate myself here. You can start to see here on the periphery that there's the appearance of these subtle reticular abnormalities and ground glass opacities bilaterally. As we get into the mid and lower regions of the lungs, you can start to see increased ground glass and reticular abnormalities, as well as the development of traction bronchiectasis in the extreme bases of the lungs. And there is an absence of what we call honeycomb features. So this was interpreted as mild to moderate basilar predominant reticulation with ground glass and traction bronchiectasis without definitive honeycombing. The radiologist put this in the category of a probable usual interstitial pneumonia pattern. And then since that CT scan, she saw a rheumatologist and was diagnosed officially with rheumatoid arthritis. So she was given a diagnosis of rheumatoid arthritis-associated interstitial lung disease. The treatment approach after my discussion with her rheumatologist was to go for rituximab, which would cover both her lungs and her joints. Her rheumatologist also put her on hydroxychloroquine and a dose of prednisone for additional joint control. And thankfully, for the first year following this diagnosis and on therapy, she has had stability based on symptoms, both lung and joint disease, stable physiology, and stable imaging findings. So with that, we're going to talk about pulmonary manifestations of autoimmune disease. So as many of you know, the lung is a common place for autoimmune disease to manifest. And so not only in cases like ours with rheumatoid arthritis, we can see that in polymyositis, dermatomyositis, systemic sclerosis, lupus, mixed connective tissue disease, and Sjogren's syndrome. Now, while all of these can manifest in the lung, it depends on the underlying autoimmune disease in terms of what we see in the lung, so which compartment is involved. So whether it's ILD, airways, the vascular system, or the pleura, it's really important to know what the underlying autoimmune condition is. And so you can look here on the table, depending on whether or not you have systemic sclerosis, the likelihood for ILD and vascular disease is obviously quite high. And in contrast, we can look at lupus, where pleural disease and alveolar hemorrhage is far more common. Often the lung disease in these patients is typically mild, but in my world, it is very progressive and can dominate the clinical picture. So interstitial lung disease complicating autoimmune disorders accounts for approximately a quarter of all of our ILD mortality. It accounts for 2% of all respiratory deaths in the United States. At the time of diagnosis, the underlying autoimmune condition is usually clinically evident, but the lungs can be the presenting manifestation of an underlying autoimmune disease, and like this case, it can present concurrently. So what is ILD and why is RA important? So interstitial lung disease, often used interchangeably with terms like pulmonary fibrosis and diffuse parenchymal lung disease, are actually umbrella category terms that encompass over 100 different conditions. They're classified here because of similar clinical, radiographic, physiologic, and or pathologic manifestations of disease. But it's not just the interstitium that's involved. I'll admit there are some airways involvements related to the interstitial lung diseases that we care for, as well as the alveoli. The common clinical presentation here includes dyspnea, abnormal imaging studies, restrictive pulmonary physiology, and an increased AA gradient. Many of you may be familiar with how we classify these diffuse parenchymal lung diseases. They're often grouped based on etiology. So in our first category here, we have exposure-related interstitial lung disease. So we have occupational ILD that we call pneumoconiosis, environmental interstitial lung disease that we refer to as hypersensitivity pneumonitis, and then medication or drug-induced interstitial lung disease. The second major category of diseases is called the idiopathic interstitial pneumonias. This is where we get our reputation for alphabet soup. But in here, we have our most common interstitial lung disease, that of idiopathic pulmonary fibrosis. I'll have one slide on this just after this, but there are 7 other conditions in this idiopathic interstitial pneumonia group. Of course, here's what we're talking about today. RA sits in our autoimmune form of interstitial lung disease, and this is our miscellaneous category group. So idiopathic pulmonary fibrosis, while the talk is not on IPF, I think it's important to understand just a little bit about this poster child within our ILD group of diseases. So while it's a rare condition, it is the most common of our interstitial lung diseases. It is characterized by this usual interstitial pneumonia pattern on CT scan and histopathology. It's associated with a poor prognosis with a median survival of about 3 to 5 years. And a lot has been learned about this condition over time. So it's a complex genetic disease with contributions by MUC5B and telomerase mutations. It's a disease associated with aging. So we're increasingly understanding that molecular drivers include telomere dysfunction and shortening and cellular senescence. And the treatment paradigm has really shifted in the last 10 years from away from immunosuppression and towards novel antifibrotic therapy. So why is finding a CTD like rheumatoid arthritis important in the diagnosis of ILD? Well, it's twofold, for prognosis and for treatment. So on this figure here on the right, you can see the Kaplan-Meier curves for those with an idiopathic interstitial pneumonia with the solid black dots is far worse than those who have a connective tissue disease associated interstitial lung disease in these open circles. Further, our approach to treatment depends on diagnosis. So in our ILD world, we really focus on trying to distinguish those with IPF and non-IPF forms of interstitial lung disease, because those with IPF, we avoid immunosuppression because that's been associated with increased morbidity and mortality, and instead treat with antifibrotics. However, if you have a non-IPF form of interstitial lung disease, our first-line therapy is typically immune suppression. So what do we know specifically about RA-ILD? So rheumatoid arthritis, as many of you know, is a symmetric and inflammatory polyarthritis of unknown etiology. It affects 1% of the general population, and joint involvement typically involves the hands, wrists, shoulders, hips, knees, and feet. This leads to inflammation of the synovial tissue, leading to swelling and pain, and if left untreated or undertreated, can lead to erosions and joint deformity. Patients will typically have circulating serologic markers to rheumatoid factor and anti-CCP antibodies, and risk factors for the development of RA include older age, female sex in a 2-to-1 ratio, genetics, and smoking history. And of course, there are many extra-articular manifestations of RA, including the skin, eyes, lungs, bone marrow, and blood vessels, among others. So what we know about the lungs in RA is the majority of respiratory symptoms occur within 5 years of RA disease onset. However, as mentioned previously, the lung disease may precede the RA joint disease in up to 10 to 20% of cases. That being said, ILD is one of the most common manifestations of RA lung disease, but you can see here on the table on the right that there are several different compartments that RA can affect in the lung: the pleura, the airways, nodules, and vascular disease. And of course, because of the medicines that we use to treat RA, they're at risk for opportunistic infection as well as drug toxicity. So what's the impact of having ILD in RA? So you can look here on the Kaplan-Meier curve on the left-hand side. So these are among RA patients. If they had a diagnosis of ILD, they had a survival curve that was far worse than those that did not have ILD. And this ILD confirmed 2.42 times the risk of death in RA. If you look here, this is a different study that looked only at RA-ILD patients using Medicare claims data, that they had a 36% mortality rate at 5 years. And in the first 5 years following diagnosis of their ILD, they occurred substantial yearly healthcare costs, both in the inpatient setting as determined by these dark gray bars, as well as the outpatient setting in the lighter gray bars. So what do we know about the epidemiology of RA-ILD? Well, you can see here, it's the same study using Medicare claims data. This is a little hard to see the difference, but this bottom line here is the incidence rate, and it's relatively flat over time, but the prevalence is increasing over time for RA-ILD. We believe that clinically significant RA-ILD, meaning those that require treatment, are at least present in 10%, if not more, of patients who have RA-ILD. And we are also recognizing that there is a high prevalence of early disease, anywhere from 30 to 60%, depending on how we define it. The mean age of diagnosis is in the mid-60s, and this, in contrast to the RA joint disease, is a male predominant condition in a 2-to-1 ratio. So there are numerous risk factors that have been identified for rheumatoid arthritis-associated interstitial lung disease. Of course, aging is a key risk factor, smoking history. Many studies have shown associations between seropositivity for RF and anti-CCP antibodies as being risk factors, as well as the disease activity of the rheumatoid arthritis. I don't have time to go through all of these, but I do want to share with you some of the work that we've done in the genetic risk factors for RA-ILD. So we performed a genetic case control association study where ILD status was assessed by CT scan for the majority of patients, and all subjects were assessed or genotyped for the MUC5B promoter variant, which is the biggest genetic risk factor for idiopathic pulmonary fibrosis. We included a French discovery cohort, a replication step with multinational samples, and then a combined analysis that led to 620 RA-ILD patients, 614 RA-no-ILD patients, and over 5,000 controls. And what you can see here on panel A, this is, there was no difference in the MUC5B promoter variant among RA cases who did not have ILD compared to healthy controls. But in contrast, in panel B, you can see that those that had RA-ILD had an increased odds for having the MUC5B promoter variant compared to controls. When we looked at this further, this was really driven by those with a UIP pattern of disease. And so we'll just step through this very briefly here. This is RA-ILD versus RA-no-ILD with an odds ratio of 3.1. If we restricted this analysis to RA-ILD patients with a UIP pattern compared to RA-no-ILD, that odds ratio increases to 6.1. If we look at RA-ILD patients without a UIP pattern compared to RA-no-ILD, there is no difference or no increased odds of having that promoter variant. And then if you look amongst RA-ILD patients only, the RA-UIP patients are the ones that have an increased odds of having the MUC5B promoter variant compared to RA-non-UIP. So this brings me to the discussion of phenotypes in RA-ILD. So RA is also unique amongst all the connective tissue disease ILDs in terms of the type of radiology and histopathology that we observe. So for most of our autoimmune conditions, we see NSIP as the predominant phenotype amongst these other conditions. And UIP is very, very low. But in contrast, RA-ILD, we see far more prevalence of the UIP pattern and less so of the NSIP pattern. And this is clinically significant in this patient population. And so if you look at RA-UIP patients, they have a survival curve that mimics that of IPF and is better than their RA non-UIP counterparts. So how do we diagnose RA-ILD? Well, in established RA-ILD, of course, you're going to want to get a good history, focusing on respiratory specific symptoms and a complete physical exam. You're going to want to understand the background RA, the articular disease activity and past treatment, and of course, ascertain risk factors for other ILDs. You're going to want to obtain pulmonary physiology and imaging using high resolution CT scan. And in certain circumstances, you may consider a bronchoscopy or even a lung biopsy. So symptoms can be very challenging in this patient population. Of course, dyspnea can be due to any number of causes: deconditioning, musculoskeletal or extrathoracic manifestations of disease, cardiac disease, anemia, and pulmonary embolism. And often the patients are having pain, so it's really not, patients really don't report having dyspnea because they have limitations due to their pain. So it's very important to remember that the absence of dyspnea does not exclude the presence of ILD in this patient population. On physical exam, if they have fibrotic interstitial lung disease, you'll often hear crackles. Clubbing tends to be uncommon. We always want to check for desaturation with ambulation, but that can be difficult because our patients may have limitations due to ambulation due to their RA disease. Now, while I told you that disease severity is a risk factor for the development of interstitial lung disease, the presence and severity of articular RA actually doesn't inform the severity of the lung disease. So what you can see here is a table from a study published in 2018, where on the top row we have different RA disease severity metrics. So the DAS28, joint swelling, joint tenderness, the patient global, and ESR. And these are correlated with lung disease severity metrics. So FVC, DLCO, and some radiologic features. And you can see pretty much across the board that there is no correlation between RA disease activity with lung disease severity. So what other risk factors should we be looking for? Well, smoking is the big one. So smoking is a risk factor for not only RA-ILD, but also idiopathic pulmonary fibrosis and our smoking-related interstitial lung diseases of desquamative interstitial pneumonia and respiratory bronchiolitis-associated interstitial lung disease. And of course, when you're assessing dyspnea in your patient, the more common manifestations of emphysema and COPD should not be ignored. Medications are a big one. So a lot of our RA patients are on novel therapies, and some have been associated with lung toxicity. We use a website called pneumatox.com to assess whether or not we should be worried about particular medications. So you go to this website, put in the generic name. If there are associations reported with your medication, you can get not only the pattern of lung involvement, but also the frequency that it's been reported. So you can get a sense of the likelihood that this medication that you're using is associated with lung toxicity. Now with that, I don't have time to go through all of the drug toxicities associated with RA treatment, but I am going to talk about one in particular, which is methotrexate. So this is, as you know, is a key medication that we use to treat RA, and it is known to cause an acute form of interstitial lung disease called acute hypersensitivity pneumonitis. But for a very long time, there's been controversy on the role on the development of fibrotic interstitial lung disease among methotrexate users. So we performed a case control study with a discovery and again, an international replication cohort using 410 RA patients with fibrotic ILD and compared them to 673 RA patients without ILD. And this is what we found. So we found an inverse relationship between methotrexate use and fibrotic ILD, and you can see the forest plot of the odds ratios across our several cohorts here. Methotrexate ever use was less frequent among patients with chronic fibrotic RA ILD compared to no ILD. And amongst those who had RA ILD, the ILD detection was delayed in methotrexate ever users compared to never users by over 7 years. So of course, you're going to want to ask about their job, ask if they've been exposed to any toxic dust, chemicals, or fumes, and whether or not any respiratory protection was used because they can still develop a pneumoconiosis. And then of course, you're going to want to identify those exposures. So this is where we get to ask all the strange questions about birds and bird feathers and exposures to molds. But just as with any other patients, RA patients can develop hypersensitivity pneumonitis. So pulmonary function testing in RA-ILD is often nonspecific. When present, restriction is the most common feature with reduced FVC and TLCO in a normal or increased ratio. Like our patient, impaired gas exchange may be present, so a decreased diffusing capacity or PaO2, increased AA gradient, and desaturation on exercise oximetry. Again, here, normal PFTs or resting ABGs do not exclude the presence of ILD. It just gives us a sense of their disease severity. So now we're going to go on to talk about imaging findings in RA-ILD. So the HRCT is one of the most important diagnostic tests in the evaluation of ILD. While a non-UIP pattern, as we've discussed, is most common in other forms of connective tissue disease ILD, the UIP pattern is one to note in RA-ILD. Not only can we get a sense of pattern in these conditions, we can see varying degrees of fibrosis and inflammation, and we can also get a sense, obviously, of disease severity. So I'm going to take just a small detour because anytime I talk to a broader audience like this, I have to talk about preferred imaging. So chest x-ray is not helpful when we're thinking about interstitial lung disease. You can see 4 representative PA films with different etiologies of interstitial lung disease, and they all kind of look about the same. Further, we're going to talk about which type of CT scan we're going to want to get in these patients. So we really prefer high-resolution CT scan chest imaging. Not only do we get thin cuts of the lung, but we also get supine, prone, and expiratory images. And in the next couple slides, I'll give you some examples as to why. So here, in a non-contrast CT scan, all the images are obtained in the supine position. And you can see here, this particular patient has these ground glass, mild reticular opacities here in the bottom regions of the lungs. However, in a high-resolution CT scan, we put them in the prone position, and you can see that these ground glass and reticular opacities have resolved, suggesting that this was not, in fact, an interstitial lung disease, but gravity-dependent atelectasis. The other main reason we get this is because we want to look for small airways disease. So inspiratory scans is the standard for non-contrast CT scans, but in high-resolution CT scans, we get expiratory images, and you can see here, hopefully this shows up okay, that there's differential regions of lung attenuation suggesting gas trapping. And when this occurs, we think of small airways disease. And small airways disease can help us narrow the differential diagnosis for our patients in our clinic. So HRCT is really the key to diagnosing interstitial lung disease. That pattern of abnormality can suggest a specific ILD. It can subsequently guide additional diagnostic testing, and for many patients can be sufficient for diagnosis. So here I'm going to show you what usual, I've already talked a lot about UIP pattern, but I thought I'd show you exactly what it is. So usual interstitial pneumonia pattern, these are reticular opacities in a patchy and basilar subpleural distribution with traction bronchiectasis, very little ground glass, and this classic honeycomb features of the lung that are shown very beautifully here. Now, UIP is a pattern and not a diagnosis. It often gets conflated with the diagnosis of idiopathic pulmonary fibrosis, but UIP is a pattern that can be seen in a variety of different interstitial lung diseases, including RA-ILD. So what does that really mean? So when we talk about UIP pattern, it really just tells us the likelihood or the level of confidence that we are going to find that UIP pattern on a lung biopsy. So we're trying to avoid lung biopsy when we're making the diagnosis of idiopathic pulmonary fibrosis. So you can see here, depending on the radiologic category that a patient has, that level of confidence for UIP on histopathology goes anywhere from greater than 90% to no better than a coin flip. Once you know the radiologic pattern, you can then come up with your differential diagnosis based on the likelihood of finding UIP pattern on a surgical lung biopsy. Our group also looked at this specific pattern in RA-ILD. UIP, again, in this disease has very high specificity, 96% for UIP on histopathology in RA-ILD, but similar to the IPF literature, it is not as sensitive, or it's 45%. And you can see why that is. So the prevalence of UIP by radiology is 29%, whereas if you were to biopsy everybody with RA-ILD, which we don't do, but if you were to do that, the prevalence of UIP on histopathology would be 61%. So bronchoscopy is sometimes obtained in our patients who have RA, and we only really get it if you're worried about infection. So they have signs or symptoms of infection, or the CT scan looks like they might have an infection, you might consider a bronchoscopy in that diagnostic evaluation. Even more uncommonly is a surgical lung biopsy, but there are certain circumstances where we're going to want to consider this diagnostic tool. So really we would pull for this if the clinical picture doesn't fit, or an alternative etiology like a malignancy is possible, or the CT scan really doesn't just jive with RA-ILD. Clearly, the benefits must outweigh the risks of this procedure, and I can't emphasize enough, right now, the current paradigm does not require the determination of the underlying histopathology in order to treat a patient with RA-ILD. And our group really likes to have a multi-D approach before recommending surgical lung biopsy to make sure that we're not missing anything. So really, when it comes to diagnosing RA-ILD, you just want to make sure that the clinical picture fits. Confirm the RA diagnosis, talk to your rheumatologist. Consider alternative etiologies. Does the radiology fit with what you would expect a patient with RA to have? And only consider more invasive diagnostic tests in specific circumstances. So concluding that you have ILD that is RA associated really is a process of elimination. So this really highlights our approach. It is a little cumbersome, but it is one of the reasons I come to work every day, is I get to work with amazing people, pulmonologists, rheumatologists, radiologists, and pathologists. We all get together and try to integrate the clinical, radiologic, and pathologic data in order to come up with a multidimensional and multidisciplinary approach to diagnosis. So now we're going to transition to management. So once we have that multi-D diagnosis, we provide all of our patients with education and self-management strategies. We also refer to pulmonary rehab and provide oxygen therapy when indicated. And then I'll talk a little bit more about disease-targeted therapy, but we also don't want to forget lung transplant evaluation and hospice care when appropriate. When we're talking about disease-targeted therapy, it's not just pharmacological therapy with steroids and steroid-sparing agents and antifibrotics. We do want to think about clinical trials, identification and management of relevant comorbidities like GERD and pulmonary hypertension, symptom management and palliative care involvement. Our patients have terrible symptoms of cough, dyspnea, depression, and anxiety. And of course, we don't want to forget about prevention. So vaccines, PJP prophylaxis when indicated, and smoking cessation. So our general approach to the management of RA-ILD is unfortunately not guided by very many randomized controlled trial data. It is far more experience-based than evidence-based. But that being said, at least not all cases require treatment. We treat those that are clinically significant and or have evidence of progression. In the RA-ILD space, we typically start with immunosuppression that we call lung-specific, so agents like azathioprine, mycophenolate, and rituximab, and I'll share with you some data that might support that. But of course, I have to work very closely with our rheumatologist to make sure that both the joints and the lungs are covered, and sometimes it's not as easy as we want it to be. In general, the pattern of fibrotic disease by radiology and histopathology is not used to guide treatment. So there are many factors to consider when we are treating patients who have RA-ILD. Of course, there are ILD-specific factors. The pace or the tempo of the disease is important, the extent of disease, the disease severity. And I just told you on the other slide, we don't think about patterns. So this is not fibrotic interstitial lung disease pattern, but if your CT scan has findings suggestive of organizing pneumonia or an acute exacerbation, that pattern will impact your treatment decision. Of course, RA-specific factors, disease activity and disease severity, extrathoracic manifestations of disease, and any relevant comorbid conditions. So this is a study that one of my former fellows and now junior faculty at the University of Kansas spearheaded. And we were wondering, since there are no randomized control data to guide our treatment approach, can we use retrospective data to understand this? So the question was, does immunosuppression impact pulmonary function trajectory in a multi-site retrospective cohort of patients with RA-ILD? So patients had to have a diagnosis of RA-ILD. They were treated with either azathioprine, mycophenolate, or rituximab. They needed to have one pre-treatment PFT and one post-treatment PFT. And then we collected patients from 5 centers across the US. Of these 212 patients, 43% were treated with azathioprine, 36% with mycophenolate, and 20% with rituximab. And what you can see here is T0 is the treatment initiation time point. So you can see the pre-treatment lung function trajectory was down, but after treatment, there was stabilization in both the FVC as shown in panel A and the DLCO as shown in panel B. And this was statistically better than if you were to continue the pre-treatment trend. There was no difference between mycophenolate and AZA versus mycophenolate versus AZA or Ritux versus AZA, but we have a sample size issue when it comes to really definitively saying one agent may or may not be better than another. So there have been some randomized controlled data, and I'm going to share with you 2 trials. The first is the INBUILD trial. So this included non-IPF fibrosing interstitial lung disease, which included RA-ILD patients. They had to have more than 10% extent of fibrosis by CT scan and those pulmonary function test parameters listed there. And their protocol defined that they had to have progression of their interstitial lung disease within the preceding 24 months despite usual care. Patients were then randomized to either placebo or nintedanib, which is an antifibrotic approved for the treatment of IPF, and their outcome was rate of FVC decline over 52 weeks. And what you can see here is that those randomized to nintedanib on the top dark blue arm had a slower decline in FVC compared to those randomized to placebo in the light blue line. Now they've gone on to publish a subgroup analysis looking at autoimmune-related interstitial lung disease. So among those that had autoimmune ILD, 82 were on nintedanib and 88 were on placebo. And you can still see that they met their primary outcome of annual rate of decline over 52 weeks, as well as some secondary outcomes related to FVC. RA-ILD patients constituted approximately 50% of this autoimmune cohort, and UIP pattern was seen in approximately 75% of this autoimmune cohort. The next trial I want to share with you is that of the TRAIL trial spearheaded by Josh Solomon over at National Jewish. This was a randomized, double-blind, placebo-controlled phase 2 trial of 123 RA-ILD participants. They were randomized to pirfenidone versus placebo, and their primary endpoint was a composite one, FVC decline of 10% or more or death. They had key secondary endpoints, including change in absolute FVC and FVC percent predicted, and this trial was stopped early due to slow recruitment in the COVID-19 pandemic. So what you can see here on the table on the left is that they did not meet their primary endpoint. So decline in percent predicted FVC by 10% or more, or death was no difference between the pirfenidone and the placebo group. However, very interestingly, their secondary outcomes were achieved. So you can see FVC on the top row here and FVC percent predicted on the bottom 2 panels here. Those randomized to pirfenidone are here in the blue line, or the blue bar, had a slower decline in FVC or less decline in FVC compared to those on placebo. And then same here, you can see the FVC line for pirfenidone versus the FVC line for placebo. So the comprehensive care of patients with RA-ILD should be multimodal and multidisciplinary. In those that require pharmacologic treatment, you typically want to start with lung-specific immunosuppression. And in those that have progressed in the preceding 24 months, despite usual care, nintedanib can be used as it has been shown to decline in slow the decline in FVC compared to placebo. And it has since subsequently been approved by the FDA for this indication. Pirfenidone can be considered, but at this time would still be considered an off-label indication. So now I'd like to end with just briefly talking about some areas of ongoing research that my group is doing. So we have two main areas of investigation in RA-ILD. First is really exploring the similarities and differences between IPF and RA-ILD, and we've now moved into early identification of ILD and RA. So since I was a fellow, we've always been interested in the overlap between IPF and RA-ILD because they have a very similar clinical phenotype. So both of them are diseases of the aging population. They affect men more than women, and they affect former smokers more than non-smokers. And this shared histopathology and radiology of the UIP pattern is unique in RA-ILD compared to all of our other connective tissue disease-associated ILDs. And some of our work has contributed to our understanding of these conditions. So I already shared with you that those with a UIP pattern in RA-ILD have a survival curve that mimics that of IPF. We've gone on to show that risk factors for death in RA-ILD are identical to risk factors for death in IPF. We've shown that there is genetic overlap with the MUC5B promoter variant in RA-ILD, which is shared with IPF, and others have gone on to show that telomerase gene mutations are also relevant in both of these patient populations. And then we've gone on to look at the biology. So there are shared, but also different lung tissue transcriptomics and proteomics. As well as more recently, we've identified telomere length similarities between RA-ILD and IPF. And so we see short telomeres not only in the peripheral blood, but also in the type 2 cells of the lungs. And so there's increasing data that there are shared features between IPF and RA-ILD across several domains. And some of the differences are also very interesting, suggesting additional biologic mechanisms might be relevant. Obviously, they have underlying autoimmune condition, but this has not only led to a lot of academic productivity for myself and others in the last 10 years, but we're really interested in it because of the clinical implications. So what does it mean for diagnosis and treatment for these patients who have RA-ILD? So I've already shown you this slide. We really focus hard on trying to distinguish those with IPF versus non-IPF forms of interstitial lung disease. And the reason for that is we avoid immunosuppression in IPF because there are data that show that there's increased morbidity and mortality with the use of immunosuppression in this patient population. However, it is unclear if this harm translates to other people who have UIP forms of disease like RA-ILD. And so that has been the underpinning of a lot of work that we've been doing and has recently led to the funding of this study called the Mountain Study. So here is our current standard of care where we diagnose RA-ILD, give most patients immunosuppression. Some will respond, some will progress. Those that progress will have irreversible loss of lung function due to progressive fibrosis, at which point we can give them an antifibrotic, then some respond, and then others progress to end-stage lung disease. And what we'd like to do is really try to change that to a new paradigm where we diagnose RA-ILD and we risk stratify patients upfront based on novel radiologic and blood-based biomarkers. That way, at the time of diagnosis, we know whether or not to observe a patient, give them immunosuppression, or give them an antifibrotic. And with this approach, we hope that there's less harm with decreased exposure to potentially toxic medications, that we identify more responders, and as such, delay the development of end-stage lung disease. So the overall objective of this proposal is to identify patients with RA-ILD that are at the highest risk for progression at the time of diagnosis, with our hypothesis being that novel quantitative imaging and specific blood markers will be able to help us with that decision-making. So in order to achieve those aims, we've developed a prospective multi-site cohort study of RA-ILD treatment. We have collaborators at San Francisco, at the University of Kansas, and the University of Michigan. We'll be collecting both lung and room-specific features of disease and plan to enroll at least 354 RA-ILD patients prior to the initiation of lung-specific treatment. We'll monitor these patients with lung function and CT imaging over 2 years, leveraging clinical care with baseline and follow-up biosample collection. And we're really excited about some novel applications, including AI-based imaging analysis. So finally, I think I have time just to share with you my other kind of project that's so close to my heart. So Surprisingly, as of today, there are no society-based guidelines for lung screening in autoimmune disease. And it seems kind of crazy as a pulmonologist to think that that's the case, but there are none. And as an ILD clinician, we see patients too late in their disease course. And so we know that patients are at risk for developing interstitial lung disease because perhaps they have a family history of pulmonary fibrosis or they have an underlying autoimmune condition like RA. Unfortunately, I see patients here at this stage of disease. It's a typical time of diagnosis when a lot of the lung is already scarred. They're very symptomatic from their condition. It's associated with a poor prognosis, and we have very limited therapeutic options at this stage. But clearly, the majority of patients will transition to that phase through an early disease phase. And these early disease phases are associated with little to no symptoms, but large population-based cohort studies like those out of Framingham have told us these early disease abnormalities are important because they're associated with all-cause mortality. So what we've gone on to do is to screen RA patients as the RA being the risk factor for interstitial lung disease. We've assessed them with questionnaires, assessed risk factors for interstitial lung disease, RA disease activity, and their treatments for RA. We've screened their lungs with lung function testing and CT scan imaging and obtained biosamples. And in collaboration with our radiologists, we've defined them as remaining at risk because they have underlying RA but no abnormalities on CT scan, but then those that have early subclinical interstitial lung disease. And with that, across all comers of age greater than 18, we identify subclinical RA-ILD in 21% of patients. But when you look at those 38 subjects out of 184, all of them are above the age of 45. So clearly age is a risk factor here, and above the age of 45, the prevalence of subclinical RA-ILD is over a third. Similar to established forms of interstitial lung disease in RA, the risk factors for subclinical RA-ILD are very similar. Age and MUC5B are predictors of subclinical RA-ILD as they are in established RA-ILD. We've recently followed up on these participants, 20 out of the 38 subclinical subjects with a median follow-up of 3.5 years. 3 have died in this subclinical cohort of non-pulmonary causes, which aligns with what we've seen in the Framingham data. And the remainder have had follow-up PFTs and/or a repeat CT scan. And 41% have had progression, either by FVC decline of 10% or greater or progression by CT scan. So now my group is working on getting the remainder of these subclinical RA-ILD patients in for repeat testing, as well as some age and sex-matched RA controls. So really, we're hoping this work will help us refine who of the at-risk population should get screened for interstitial lung disease. And then when we find those who have early interstitial lung disease, who should be treated and with what? And if treatment affects the development of this clinically significant established form of disease. And so with that, I'll conclude. ILD is an important comorbidity in patients with RA. RA can involve any lung compartment, and respiratory symptoms are often nonspecific. Identifying the presence of RA and ILD has significant implications for treatment and prognosis, so it's really important to have a high level of suspicion for this. HRCT is a key diagnostic tool in the evaluation of patients with ILD. Working with a multidisciplinary team is essential, and the management of RA-ILD requires a comprehensive approach and is thankfully evolving. So I can't do this talk without thanking so many people, both from the clinical side of things and the research side of things, as well as our funders. And here is an extended list of people who've helped me along the way. And with that, I'm happy to take any questions.
Dr. Lee, thank you. I'm going to throw it open to our audience to get things started. And while we're waiting for a question, I want to ask you maybe to start where you ended your talk, which is this subclinical population with RA. They're probably being managed in our resident clinics and our primary care clinics. They may or may not have co-management with a rheumatologist. They're probably not seeing a pulmonologist if they are asymptomatic. What do you want our primary care doctors to do with this population? How should they start that work up in this group? Who should see your group ultimately?
Yeah, so I think first is to ask questions about dyspnea and cough, right? Because even though we think they're asymptomatic, if you actually ask a lot of questions, they'll tell you, oh, I think I have a lot of fatigue, or I just feel like it's because I'm getting older, or maybe I've gained 10 pounds in the last year. So they attribute a lot of their symptoms to other things that may be going on. So I would ask more questions about symptoms. I would make sure you get pulmonary function testing. In the primary care population, it's still good to check those medications because all of those early abnormalities may or may not be due to the development or risk factor for developing interstitial lung disease, but maybe an early sign of drug toxicity. So you're just going to want to make sure that you know what your patients are taking, RA medication related or not. And then in those cases that you're uncertain about, just refer them to our clinic. We're happy to see them and help along the way.
Joyce, thank you. That was a great talk. I really enjoy it. Sometimes these patients end up in our clinics because they develop constrictive bronchiolitis and progressive airway obstruction. Do you know how often does that happen? Are there any new therapies for these patients?
So unfortunately, constrictive and obliterative bronchiolitis in any of our autoimmune conditions is exceedingly difficult to treat. We do give them immunosuppression in the beginning because there can be more inflammatory forms of like follicular bronchiolitis that may respond to immune suppressive therapy. But in general, it is one of the hardest things to treat because the fixed airways disease is not something that we have good medicines for at this point, unfortunately.
Hey, Joyce, a great talk and congratulations on building such a impressive program here in the years you've been here, but also keeping this research moving, really building on both fronts, which is amazing. So you had sort of alluded to these lung-specific anti-inflammatory approach early on, and then kind of said, hey, sometimes it's hard to match this with what rheumatology might be wanting to do from a joint specific. But then it strikes me, so does, for example, like the TNF blockers, did they have really no impact on the disease progression? Did you exclude those from the work you were doing when you were sort of looking at what the role of anti-inflammatory therapy was in terms of progression of disease? And if that's the case, then any thoughts as to why? I mean, do we understand this well enough to say why blocking TNF doesn't work, but going after with azathioprine does potentially work in this scenarios?
That's a great question, and I avoided TNFs for a reason because it's a whole can of worms right there. But TNF inhibitors historically have actually been associated with lung toxicity. Their association with lung toxicity probably is not as significant as originally thought based on recent meta-analysis work. But there is no data to suggest that TNF, at least as of this point, helps our patients who have fibrotic interstitial lung disease. And so it is a huge challenge to find a balance between joint-specific treatment and lung-specific treatment. We like to pull for mycophenolate, and that does nothing for the joints. And so it's really a collaboration with the rheumatologist to figure out how we can immunosuppress a patient as carefully as possible, because we don't want to load immunosuppressant on top of immunosuppressant because that will only lead to complications of therapy. So we try to be very targeted and very careful about our approach to immunosuppression.
Dr. Badish?
Great talk, Joyce. How closely does activity of the interstitial lung disease track with systemic manifestations of the disease?
For rheumatoid arthritis, high disease activity and serologic markers for rheumatoid arthritis, like rheumatoid factor and CCP antibody, are risk factors for development of the interstitial lung disease. But there is no correlation between the disease activity of the joints, so how bad or good the joints are controlled, and the disease severity of the lungs in terms of FVC or extent of fibrosis.
Dr. Praska?
Thanks, Joyce. We had a recent case where ID was involved in a gentleman with new RA-related ILD where there was a concern for infection, and he did get a bronchoscopy to rule out cocci and TB. He had risk factors for those. Yeah. And then the issue was he kept having fevers and whether or not they were infectious or inflammatory, and he was already on immunosuppression, so at risk for atypical infection. And in a case like that with a negative bronchoscopy but ongoing clinical deterioration, is that someone you'd recommend the biopsy for? Or maybe he should come to the multi-D clinic?
Yeah, bring that case to our multi-D conference. I mean, that is certainly a scenario, and one could consider the risks and benefits of a surgical lung biopsy. Surgical lung biopsy, when done in the right hands and in the right clinical scenario, can be very safe, but there's increasing awareness that there is increased morbidity and mortality in the poorly selected patients who go on to surgical lung biopsy. So the only thing about your history that I would worry about is the kind of clinical deterioration. When we catch patients when they're on that downward slope, the lung biopsy can make things worse. And so we worry about that particular scenario, but happy to discuss in our conference or offline another approach to your patient.
Dr. Chopra.
Joyce, thanks. That was a great talk. In fact, that was kind of one of my questions, which is when would a surgical biopsy be indicated? I've had patients where the transbronchial biopsies are otherwise non-diagnostic or inconclusive. That's fairly straightforward, depending on how the patients are looking, obviously. Are there other concrete indications where you would prefer to go to a surgical biopsy at first?
Yeah, I mean, I think scenarios in which you're considering malignancy, it could be considered in terms of getting a surgical lung biopsy if there's no other, percutaneous or non-surgical lung biopsy route to identify the malignancy. Sometimes we see weird things on the chest imaging studies, and so they don't look like interstitial lung disease. So whether it's a pneumoconiosis and it's important for, I don't know if, for example, for a workers' comp related issue, or if you're, I guess another scenario would be atypical infection here. So there are different circumstances, but the use of surgical lung biopsy in RA-ILD and other connective tissue forms of ILD is very, very low. But I didn't want people to be surprised if we recommended it in their patient, because there are unique and very specific circumstances in which we would consider it.
Hi, Joyce. Thank you for the wonderful talk. It really gave a very good overview of ILDs. My question was about the clinical trials that you had mentioned. What kind of drugs are on the horizon in terms of what can we expect in the next few years for these kind of diseases?
Oh, yeah. So there is, thankfully, a lot of interest in identifying better therapeutics, not only in IPF, which was the one where most of the focus has been on, but with the inbuilt trial, a lot of industry partners have become interested in non-IPF forms of interstitial lung disease. So we are going to be recruiting patients who have RA-ILD in several phase 3 clinical trials moving forward. So they are targeting things, different biologic pathways. The LPA1 pathway is one that's under investigation. There's a PDE4 inhibitor that's being investigated, and it is more broadly including non-IPF interstitial lung diseases, which I think will be great for our field.
We have time for just a quick question. I would ask one more drug follow-up question. I think we've sort of asked this question in ILD for all of time. We say, well, we don't know which of these drugs work, but this is a relatively common disease. These drugs could be tested head to head. Is that happening anywhere? And maybe why hasn't it happened? Why don't we know whether mycophenolate is better in this population than something else?
That's a funding question. Nobody wants to pay the money for things that I think we, the industry partners are more interested in their novel therapies. And I don't know, at some point, I would love to do a trial looking at mycophenolate, some of the things that we routinely use. But I think the space in which we might assess those possibilities is in early disease as opposed to established forms of disease.
I think we are good, and we are just about at time. So I want to, as one reminder for folks who were promoted and were recognized at the start of our talk, please pick up your certificate before you leave the room today if you came in a little bit late. And Dr. Lee, thank you very much for this excellent work.
Thank you very much.